Dear colleagues, the video I am about to present to you is of great interest. The patient came in for first trimester screening. The fetus has a neutral translucency of 0.9, a normal nasal bone, a perfect and normal ductus venosus, and normal intracranial translucency. During the evaluation of the fetus, we identified at the level of the cardiac circulatory system the presence of an anomaly in the arch. This anomaly is detected at a very early stage. Normally, we are used to making these diagnoses essentially at the structural stage. The advantage of performing a translucency scan not at 11 weeks and 3 days, but at 13 weeks. As in this case, this is the concept we have been trying to emphasize for some time now. It allows for a more detailed analysis of the fetus. And most importantly of all, it allows us to thoroughly examine and evaluate structures such as the cardiac circulatory system, which at 11 weeks are more challenging and difficult to diagnose, even with the aid of the transvaginal probe, compared to the abdominal one. In this case, we can see an anomaly of the arch in which the aortic arch is present on the right side, essentially in relation to the trachea, with the ductus arteriosus originating from the pulmonary artery, which instead is present on the left side. So the classic design that we normally refer to as the three-vessel trachea view is lost, and essentially we observe this image. This is due to the persistence of a right aortic arch and the regression of the left arch. This patient essentially receives thorough counseling on the need to undergo an invasive investigation. Given the well-documented clinical association of this particular condition with DiGeorge syndrome, it remains a key factor even when there is a complete absence of other evident associated anomalies during this type of clinical examination. First of all, I wanted to remind you with a few concepts. These anomalies actually concern the structure that connects the ascending aorta with the descending aorta, which constitutes the aortic arch. Most of these forms are relatively straightforward and common anatomical variants that typically do not result in any clinical complications. In other cases, however, these anatomical variants can be directly implicated in the structural development of vascular rings. These vascular rings, which can be complete or incomplete, may encircle the trachea and the esophagus and can consequently result in a variety of respiratory or digestive symptoms. In these newborn infants and developing fetuses, this condition manifests as significant respiratory and breathing difficulties due to compression at the tracheal level, persistent difficulties with the swallowing process and dysphagia due to compression occurring mainly on the esophagus, as well as the development of abnormal blood flow patterns. The regular flow of blood. However, in the vast majority of cases, these forms turn out to be minimally symptomatic or even completely asymptomatic and silent in many cases, and can persist throughout an individual's entire life without causing any symptoms at all. It is estimated by some experts that approximately 1 to 2% of the general population appears to be impacted by various types of arch anomalies. However, as I mentioned earlier, it is exceptionally challenging to accurately determine the true prevalence of this specific type of condition. This is also because in most cases they tend to progress with very few or even no noticeable symptoms at all. And so it is essentially quite difficult to establish the correct prevalence in a definitive way. Also because sometimes even an accurate prenatal diagnosis proves to be difficult. There are even some studies that report much higher prevalence rates, which would actually be, thank you. This occurs in approximately 1 out of every 1,000 pregnancies. Therefore, in this specific clinical scenario, we would be talking about arch anomalies with a prevalence that is significantly higher than what we are accustomed to seeing us. So, to recap, the right-sided aortic arch is certainly among the arch anomalies. The most common one results from a premature closure of the left aortic arch with persistence of the right one, which gives rise to the brachiocephalic trunk on the left, while on the right it gives rise to the subclavian and carotid arteries. Let's say that this condition is often closely associated with various types of heart diseases. In our specific case, even though we are currently in the middle of a comprehensive first trimester screening process, it fortunately appears that there are clearly no associated cardiac anomalies present. The definitive diagnosis is typically established on the three-vessel trachea view. where the distinctive anatomical configuration created by the aortic arch is no longer visible. Between the ascending and descending aorta and the ductus arteriosus, which originates from the pulmonary artery, both are normally to the left of the trachea. However, in this case, instead of forming a V, a U is formed with the aortic arch on the right, with the ductus arteriosus on the left in relation to the trachea, which appears as the smaller anechoic area. Sometimes it can be associated with cardiac pathologies, the most frequent of which is tetralogy of Fallot. And there are also associations with genetic conditions such as DiGeorge syndrome. Therefore, it is always necessary to advise the patient to undergo a fetal karyotype study in order to discuss this type of genetic correlation. Lastly, I just want to reiterate the concept that performing a first trimester screening at 13 weeks, as in our specific case, allows for a much more detailed and accurate assessment of the developing fetal anatomy. That nowadays neutral translucency is no longer based solely on the evaluation of the neck, nape, and nasal bone, but by taking advantage of a slightly more advanced stage of pregnancy, it is possible, using both the transabdominal and transvaginal approaches, to conduct a much more comprehensive anatomical study of the site. Thank you for your attention.